Pathology Part 2. Today, we have a very interesting talk, which is a very seemingly difficult topic and is going to be made very easier over the next hour or two. How a pathologist can suspect immunodeficiency. It will be chaired by Honorable Dr. Mukesh Desai. He is the Chief of Immunology at the Department of Inborn Errors of Immunity at the BJ Wadia Hospital for Children, Mumbai. He is also the consultant hematologist at Nanavati Hospital, Mumbai. Our speaker for today is the most eloquent and knowledgeable Dr. Biman Saikia. He is a professor in immunopathology at PGIMR, Chandigarh. I will be moderating the session. I'm Dr. Shrutika Java. I'm a consultant hematopathologist at Jaslok Hospital, Mumbai. My co-moderator will be Dr. Sindhura. She is an associate professor in pathology at KMC, Manipal. This webinar is hosted by Dr. Borges Madam and Dr. Sumit Gujral sir, who both need no introduction. Some reminders: if there is any connection interruption or sound or video issues, please leave the meeting and rejoin with the same link. Please answer all the poll questions in the chat box and do not send requests for annotation to the presenters. That's very distracting. There are a couple of disclaimers. We have some interesting upcoming talks. The next is a slide seminar by Dr. Rajiv Kaushal and Gaurav Narula on immunotherapy, which is an extension of this topic. A talk next Tuesday on neoplasia by Dr. Borges Madam. Let's start. Over to you, sir. I welcome Dr. Saikia, sir, and invite him to start his talk.
Thank you, Shrutika, and good evening, everybody. So the topic I've been given today is on immunodeficiencies. And I'll share my screen now. Is my screen visible?
Yes, sir.
And I'm audible?
Yeah.
Yes, sir.
Right. So the topic is how a pathologist can suspect immunodeficiency. And so what is immunodeficiency? Immunodeficiency is basically the inability to produce an adequate immune response because of an insufficient any component of the immune response that is not enough. That may be absence of antibodies, immune cells, or both, or the regulation of that immune system. So immunodeficiency we can broadly classify into primary, and which we also call as the primary immunodeficiency diseases, or more lately the inborn errors of immunity, or the IEI, and the secondary immunity. And in clinical practice, you handle more of secondary immunodeficiencies rather than the primary, and primary is supposedly rare. And there are a host of causes for secondary immunodeficiencies, and we are familiar with it: infections, malnutrition, immunosuppressive drugs, and age, extremes of age, both prematurity and old age. So there are a lot of factors which are basically causes for secondary immunodeficiency. And there's a certain amount of overlap between primary and secondary, because even in primary immunodeficiency, there are certain factors like impaired specific immunosurveillance and chronic tissue inflammation and transforming viral infections, which are basically extrinsic causes, but also contribute to the primary immunodeficiency. So this is a host of causes for secondary immunodeficiencies: viral infections, acute bacterial infections, malignancies, and most of them, and extremes of age and all. So the immune system is quite simple. You just need to know all these crisscross connections, and how to suspect immunodeficiency. Obviously, you have to be suspicious, and the meaning is that suspicious means that something that makes you feel that something is wrong somewhere. Okay, so you have to be suspicious. And so when a pathologist suspects something, it's when a clinician suspects something, it is clinical suspicion. So if a pathologist is suspecting something, it's pathological suspicion. But since pathological, the very word means uncontrolled and abnormal, so you don't want to say it's an abnormal suspicion. So let's stick to clinical suspicion. So high index of clinical suspicion, and since we don't actually interact with the patient many times, pathologists, they are in the in the background. What they deal with is the reports and the results of tests. So we should not, if you have something in mind, we should not hesitate to pick up the phone and call the clinician and ask, even if they are stupid questions, and because PID lies in those stupid questions, and even if they are hi-fi questions, even there you have the IEIs, or the inborn errors of immunity. So how to diagnose PID? So the mind, the eye sees only when only what the mind knows. So the first step to diagnose PIDs is to think of PID, because if we are not aware of these conditions and we don't know, then we don't diagnose them. And the second step, again, you have to think of PIDs. So in the third step, think of PIDs louder. So we have to, know about this condition, and that's what's the aim of today's talk. I'll just try to give a brief of, just a summary of, because it's not possible to cover all the PID disorders in a single talk and in a limited time. But I'll try to give you an overall concept of the primary immunodeficiency diseases. Now, when we hear hoof beats, we think of horses. Okay, so that is our usual practice. But they can also be zebras. So we have to think of the rare things too, because even they are equally important. So we have to think zebra, and that's what the Immunodeficiency Foundation says, think zebra. Also think of, that means also, apart from the garden variety of various diagnoses, also think of the rare causes, and that's how you diagnose the PIDs. So primary immunodeficiency disorders, now they are better known as the inborn errors of immunity. They are considered to be rare, but let me tell you, they are not rare. They may be uncommon, but they are not rare. If we consider the PIDs as a group of disorders, then it's not rare at all. And prevalence in some countries, it can be as high as 1 in 1,200. And it's much more common than many of the disorders that we commonly see. Like, it's 4 times more common than hemophilia, 5 times more common than cystic fibrosis, and it's as common as multiple sclerosis in the US. This is, I'm talking when you not as single conditions, but when you talk of PIDs as a group. So, and there are warning signs which help you in picking up these patients. And there are warning signs in children and in adults, and they are very similar. And the symptoms can often be very common clinical symptoms. So that's very important. And when we talk of immunodeficiency, we generally think of infections, but we have to also keep this in mind that many of these patients can also present with autoimmune diseases and malignancies as well. So infections, autoimmunity, and malignancy, all three components can be presenting features of these disorders. So in the laboratory, when you do scientific research, whenever you want to know the function of a particular molecule or a gene, what you do is you do produce a knockout mouse. Okay, you can target the total gene. Total gene can be knocked off, or you can control where and when your target gene is knocked out. So conditional knockouts and conventional knockouts. So that's how. And inborn errors of immunity basically are the nature's knockout models, and the severest form is the SCID, or the severe combined immunodeficiency, where you totally have a total lack of the immune response because the T cells are not functioning. So these are the nature's knockout models. There are certain warning signs which the Jeffrey Model Foundation have given for children and for adults, but these warning signs are more useful for the general public rather than for physicians, but they are helpful anyway. So these are warning signs that have been put up by the Jeffrey Model Foundation. But for a pathologist, I'll say that the warning signs should be, you can remember with these mnemonics: pulsin. Just let me put the pointer. Pulsin. In pathogen. Whenever you encounter a pathogen which is unusual, like Pneumocystis cerevisiae pneumonia, if the patient is HIV negative, and you don't see any obvious causes of immunosuppression, and if you find Pneumocystis cerevisiae, you obviously think of something that is wrong with the immune system, or environmental mycobacteria. So these rare organisms, rare pathogens should make you suspect. Localization, atypical localization, for example, brain abscess due to aspergillus or cerebral toxoplasmosis, pneumococcal arthritis, osteomyelitis due to environmental mycobacteria. These are very rare localizations. And whenever you see such rare localization of infections, then you should think of primary immunodeficiency underlying. Then the course, an unusual course, an unusual intensity of infection, and the number of infections. So these are other factors which should prompt you to think of underlying primary immunodeficiency. And as I said, infections are not only the features of PIDs. There are other manifestations of immunodeficiency disorders. For example, you can use the mnemonics Garfield in this. Okay, granulomas, in particularly in the lungs, lymph nodes. And we are, as pathologists, we're so used to seeing granulomas. And perhaps the commonest diagnosis we give is, granulomatous inflammation consistent with tuberculosis if we don't see a B. So that is one of the commonest diagnoses that we give. But granulomas, in particular in lungs, lymph nodes, and skin, as well as other organs, they can be seen especially in patients with CVID. CVID is the commonest form of immunodeficiency in adults. As high as 8 to 22% of CVID patients can have granulomas in the lungs or lymph nodes, which are otherwise non-specific kind of granulomas, and they are often labeled as sarcoidosis. And even granulomatous lymphocytic interstitial lung disease. So these can be presenting features of CVID. So granulomas, when you see granulomas, of course, you can see granulomas in CGD also, but otherwise, if you see granulomas in tissues like lungs and the lymph nodes, you should always think of underlying CVID or other primary immunodeficiency diseases. Autoimmunity, particularly autoimmune cytopenias, as well as organ-specific autoimmunity, celiac-like gluten-independent enteropathy. It's like, so these are some features which should, apart from infection, which should make you think of PIDs. Recurrent fevers, all the autoinflammatory syndromes that we have will have recurrent fevers. They may be periodic. So if you have a periodic fever and you don't see any obvious focus of infection, and the fever is periodic, then you can think of underlying PID in a setting of recurrent fevers. Inflammatory bowel disease, often very early onset, atypical, refractory to therapy. Eczema, lymphoproliferative disorders. So these also can be presenting features of PIDs. So apart from infections, these things all should also be kept in mind. So when you think of PIDs, you should consider three things: age of presentation, type of organism, and family history. This is very important. Age of presentation, most of these diseases will be diagnosed in the first year of life, because most of the PIDs are handled by the pediatricians. Okay? Because most of the PIDs are severe in onset, and they present very early. So, but there are some around 15% which present by 6 years and only 5% in adulthood. So you don't see much of PIDs in adult patients, but most of these will be present in the pediatric group. Okay. So this is the graph which shows that the antibodies in a child, the first part of the of life, the maternal antibodies protect the child from any infections. Okay, because gradually the maternal antibodies come down, the fetal antibodies pick up. So during in B cell deficiencies, when there is immunoglobulin deficiency, you'll see that the patients will present later in not within the first few months of life, but after 1 year, because by the time the maternal antibodies have waned off, and the fetuses or the child's antibodies have failed to pick up when there's a B cell deficiency, the first few months of life are protected in B cell disorders. So in antibody deficiencies, the patients will present later in the first after the first year of life. So the age of presentation is very important. The neonatal period, the severe congenital neutropenias, leukocyte adhesion defects, all these will present in the neonatal period. First 6 months, severe combined immunodeficiency, and 6 months to 5 years are where the antibody deficiency or the hypogammaglobulinemia will come up. So depending on the age, so the age of presentation is very important. Type of organism, I'll just come to it. See, when you look at the immune system, there are three components: the phagocytic system, the T cells, and the B cells. These are the main players of the immune system, and they are very, interacting with each other, because the macrophages, they help the T cells, and the T cells in turn help the macrophages, and T cells also help the B cells to proliferate. And these cells have specific functions. For example, the macrophages are very important to handle the catalyst positive bacteria and fungi. And the B cells are because they bring about their action by producing antibodies. So antibodies obviously will act only on the extracellular bacteria. So B cells are very important in handling extracellular pathogenic bacteria. T cells, since they are central to the whole process, they are very important in handling viruses, fungi, and bacteria as well. So if there's a deficiency in any of these components, for example, there's a deficiency in the APCs or the macrophages or the T cells or the B cells, so accordingly the infections also happen. For example, in the phagocytic defects, it's the catalase positive bacteria that are more predominantly, there, and the fungi. In the complement, there is pyogenic bacteria and viruses. In the, sorry, this is slightly interfering. Just a minute. Is it stuck? Okay, in the T cell, there is in viruses, pyogenic bacteria, fungi, everything. So because the T cells are important, so if the patient has a T cell defect, all the infections can happen. The whole host of infections, including bacteria, fungi, and viruses, everything. And in B cell deficiency, pyogenic bacteria and enteroviruses. So depending on the organism that you encounter in a particular patient, you can pinpoint which component of the immune system is gone wrong. So if we talk of PIDs in adults, as I said, CVID is the most common, but patients with known, you encounter patients with PID in adults. For a patient who was already diagnosed as a PID in childhood and now he has grown to be an adult, so that's one situation. Then we have all the late onset primary immunodeficiency like the CVID and the Good syndrome, which present later in life. So those are the kind of immunodeficiencies that we see in adults. But majorly you have the secondary immunodeficiencies, and whenever you talk of immunodeficiencies, the first thing you have to rule out is HIV infection. So that is one very important thing. So how do we classify the human inborn errors of immunity? The 2019 IUIS phenotypical classification had 430 disorders that were classified. And now the latest classification that has come up in the 2022, and now it has 485 disorders. So this classification, I call it more of a catalog rather than a classification system. And it's very difficult to remember each and everything, and it's all the time you have to refer to this catalog or the classification system. This classifies the immunodeficiencies into 10 categories, which are combined immunodeficiencies with syndromic features, predominantly antibody deficiency, diseases of immunity circulation, congenital defects of phagocytes, defects in intrinsic and innate immunity, autoinflammatory, complement, bone marrow failure syndromes, and phenocopies. So these are the 10 categories, and we'll try and cover some of these today in this talk. Okay. So when you talk of the innate immune response, we have the macrophage and the neutrophils. We know that the macrophage is equipped with toll-like receptors, and through which they recognize the PAMs and the DAMs that are present in the bacteria. So this TLR is very important. And the neutrophil, it has many proteins like the elastase, HAX1, and integrin beta 2, which actually allows the neutrophil to adhere to the endothelium and cause a diapedesis. So these are important molecules that are present in the phagocytes. So this TLR system is very important because it recognizes the PAMs and the DAMs of the microbes. And then we have the NADPH oxidase system, which is there in the phagocyte membrane, and it composed of these components. The membranous components composed of GP91 and P22, and the cytoplasmic components has 47, 67, and P40. So this is another important system that is present in the phagocyte, the NADPH oxidase system. And then we have the IL-12 interferon gamma axis. IL-12 is produced by the phagocyte. It stimulates, it helps the T cells to proliferate because they have the receptors for IL-12. And then this in turn produces interferon gamma, which again helps with phagocytosis. So this is a loop, the interferon gamma IL-12 axis, that is very important. Okay, and fourth component is the complement system. So when you talk of the innate immune system, these four components are very important in handling pathogens. So now these stars are basically patients. You can have defects or genetic defects in each of these genes, which can cause immune deficiency status. For example, in the TLR defects like TLR3 and UNC93B, these patients suffer from herpes simplex encephalitis. Rest of the organism they will handle absolutely fine, but if they have a TLR3 defect, they will have herpes simplex encephalitis. This shows how these molecules are important in handling specific organisms. In the defects in the NADPH oxidase system, the patients will have chronic granulomatous disease. Any of these components, GP91, P22, or P67, P47, any component, if there is a defect or genetic defect in these components, the patient will have chronic granulomatous disease. Okay, and in a defect in the IL-12 interferon gamma axis, this axis is very important for handling mycobacteria and intercellular organisms, because the macrophage is very important in handling the intercellular pathogens. So if there is a defect in the IL-12 interferon gamma axis, the patients are susceptible to what we call as the Mendelian susceptibility to mycobacterial disease. These patients are susceptible to environmental, very low virulent mycobacterial infections. So Mendelian susceptibility to mycobacterial disease. So let's now look at some examples. Case study: 3 months old girl presented with pneumonia, and at presentation, the patient had omphalitis. You can see here, and large perineal ulcer. And if you clearly look at the ulcer, and the diagnosis is very simple, it's straightforward. There is no pus in this huge ulcer. So because the neutrophils have, if you look at the peripheral neutrophil count, you can see very high neutrophil counts. But despite having such a high neutrophil count in the blood, the neutrophils are not there in the wound, in the ulcer, because they are not able to diapedase and go into the site of inflammation, and that's what happens in the leukocyte adhesion defect. So if we do a flow cytometry for CD18 or CD11B or CD11A, you can see that the patient has low expression of the CD18 and the CD11B, which is compared to the normal control. So this is a leukocyte adhesion deficiency type 1, where the patients can have huge ulcers without any pus. So that is very simple, and we have seen cases, and we can diagnose these simple conditions. Another case: 17-year-old boy presented to the gastroenterology unit with tender hepatomegaly. If HIV is negative, CD4 count is normal. But if you look at the immunoglobulin profile, you can see that everything is increased. So this patient has hypergamma-globulinemia, and the CT showed hepatosplenomegaly with multifocal hepatic lesions, query abscesses. Okay, so multiple pyogenic abscesses in the liver, deep-seated abscesses. So this should prompt the diagnosis in your mind. So this patient has ordered the NBT dye reduction test, and there was no dye reduction. It's a very simple slide test where you just add the NBT dye to the neutrophils. Okay, and if there is reactive oxygen species production, hydrogen peroxide production, there is the NBT dye is reduced, and there's formation of the blue formazan. In this patient, there's no formation of blue formazan granules. So this is there was no NBT dye reduction. So this gives a diagnosis of CGD, and then you can do the DHR. You can see in the normal control there's a shift in the DHR oxidation. There's a shift to the right, but in the patient you see that there's no shift. So this gives you a diagnosis of DHR. DHR is a very simple test. Doesn't cost much. You just need a flow cytometer and a DHR dye and some PMA, or even you can use yeasts to stimulate the neutrophils. Simple test, but gives you a lot of information. You can also do a flow cytometry for the specific proteins like B558, GP91 FOX, and P22 FOX. You can specifically do a staining for those molecules. And in this patient, that you can see that the B558 or the GP91 FOX is deficient here. So this gives you a diagnosis of CGD, X-linked CGD, because of defect in the B558. And CYBBG, you can do a genetic analysis, and that straight away gives you the diagnosis. So when you see the deep-seated abscesses, and these abscesses are often very difficult to drain because of the long-standing inflammation, there is a lot of granulomatous reaction, and these are very, very difficult to drain. And these patients often need to be, surgically, these abscesses needs to be surgically removed, and the patient might require hepatic lobectomy or something to remove these abscesses because they can't be drained because of the dense granulomatous inflammation. So if you see that these deep-seated abscesses, you should always suspect CGD. In a typical X-linked CGD, because it's the mother, you can see here that this is a test. There's no shift to the right. This is the control. You can see the total shift to the right. The mother, you can see there are two peaks. So this is how a typical X-linked carrier will look like in a X-linked CGD. So this is the mother with double peak, and the father is normal here. So if you see this kind of a pattern when you're screening the patient and the mother, so this should immediately give you a diagnosis of X-linked CGD. Then you can also do the flow cytometry for the specific proteins, GB91 FOX, P22 FOX, or P47 FOX, or P67 FOX. And this will again pinpoint you to which molecule or which component of that NADPH oxidase system is not working. Okay? Another case, 13, 13 years presented to the gastroenterology unit and PGI, again a solitary liver abscess, and the liver abscess grew Staph aureus here, okay? And this patient was given IV cloxacillin, discharged after 1 month. Again, at 17 years, after 4 years, he again presented with the similar complaints. Again, there were hepatic abscesses and with a subcapsular rupture. Okay, investigations, you can see that the total count is slightly raised. And what else? In the pus culture, you can see that the pus again grew Staph aureus, and the serum immunoglobulin profile is hypergamma. You can see all the immunoglobulins are increased. So there he has hypergamma. Again, the NBT dye reduction did not show. And when you do the flow cytometry, you can again see a similar kind of thing. And in the patient, you can see that the stimulation index is very low, 2.26 compared to the control and the mother. So these are again 558 expression is very low, and you can see that this is again an X-linked CGD. So multiple abscesses in the liver or lymph nodes or the retroperitoneal abscesses. So deep-seated abscesses should always suspect CGD. Okay. So this patient was discharged on antibiotics, and again at 22 years, again he presented with similar complaints, and again had a liver abscess. So multiple times the patient is presenting despite getting proper prophylaxis of antibiotics, again and again presenting with recurrent liver abscesses. So this is what happens in CGD. Okay. For now, that is all these investigations are done by flow cytometry. So for a pathologist, when you get for example, if you do an autopsy of a CGD patient and you don't have the investigations during life and the patient succumbs to the illness, then as pathologists, can we do anything? So this was a very beautiful paper from our center where they have shown that immunohistochemistry can also be done in tissues to diagnose this CGD, and they have beautifully shown, staining with cytochrome B558 or P47 FOX or P6. Here in this case, you can see that there's a lack of staining for P67 here. So this is again another case here. You can see that there is lack of P67 staining here. Okay, so even immunohistochemistry can, if you have the antibodies and you have tissues, even if you could not do the flow cytometry in time, you can still try to give a diagnosis by immunohistochemistry, and that this is absolutely possible. So first poll question: all of the following are seen in chronic granulomatous disease except, okay, which is false. I mean, NADPH oxidase deficiency, recurrent infections with catalase positive bacteria, difficult to drain deep-seated abscesses characterized by granulomatous inflammation, and hypogammaglobulinemia, which is wrong. So I guess we must have the answers by now. It's a very simple
Yeah,
question.
most of the answers are E.
Yeah, that's
Hyperglobulinemia.
absolutely good. Straightforward. These patients have hypergamma globulinemia rather than hypogamma globulinemia. So rest are all straightforward answers. So no doubt in that. Okay, another case study here. A 10-year-old boy. Now I'm talking of the innate immunity defects of the innate immunity. So CGD we have talked about, LAD we have talked about. Now this is a 10-year-old boy who presented with fever for 1 month and BCG adenitis at birth and multiple osteomyelitis like disease with lytic lesions in the bone. You can see here in the tibia, there are small lytic lesions here. So these kind of, lytic lesions in the bone with BCG adenitis at birth and presenting very early in childhood, this should raise a suspicion of MSMD. Okay, because this is a very typical osteomyelitis and typical by typical I mean environmental mycobacteria. Okay, if you try and culture these tissue from these lytic lesions, probably will grow atypical mycobacteria. So these kind of multifocal osteomyelitis like disease with in a boy, in a young boy, should always raise a suspicion for. And so you do the flow cytometry. We did the flow cytometry for multiple proteins, but the 212 here, you can see the IL-12 receptor beta 1 CD212 is deficient in this patient. Okay, see there's no staining. So this, and we did the mutation analysis, and the CD119 is normal. So there was a defect in the IL-12 receptor beta 1. So this kind of a picture, always should raise a suspicion for the MSMD kind of the defect in the IL-12 interferon gamma axis. So this is another case. Okay, he was given a 17 months boy given BCG vaccination as 3 months, and he had BCG adenitis. Okay, and excision biopsy was done, acid fast bacilli. Okay, why am I getting muted? I don't know. Can you hear me?
Yes, now we can hear you. Yes.
Okay.
Yes, sir. You're audible.
Yeah. I suddenly got muted somehow. So pyogenic bacteria and with the bilateral sensory neural hearing loss. Okay. And again, you can see multiple lytic lesions in the skull and the long bones here. So this kind of a picture, and this time the CD112 was normal, but CD119 expression was low. So this is interferon gamma receptor 1 deficiency in this child. Another case, 18-year-old boy admitted with complaints of fever, jaundice, skin lesions, and you can see that the hemoglobin was 6.7, white blood cells, the total he had polymorphonuclear leukocytosis, and had enlarged lymph nodes in the supraclavicular, axillary, mediastinal, hilar, and abdominal regions. You had hepatosplenomegaly and periportal lymph nodes, and these lesions in the skin. Okay, biopsy was done from the skin biopsy and it yielded Cryptococcus species. Now the patients with MSMD are not only atypical mycobacteria, but other intracellular pathogens as well. And that includes histoplasma, Cryptococcus, Leishmania, all those intracellular pathogens. So this skin biopsy showed Cryptococcus, axillary lymph nodes had granulomatous inflammation, showed Cryptococcus, and blood culture gave Cryptococcus. So HIV is non-reactive. That's important to rule out. HIV is non-reactive. Immunoglobulin profile, you can see there's hypergamma globulinemia here, and there was reduced expression of IL-12 receptor beta 1 even here, CD212. So patient presenting with cryptococcal skin lesions and granulomatous inflammation in the lymph nodes. So intracellular pathogens, your diagnosis should it should prompt your diagnosis towards the MSMD group of diseases due to defect in the IL-12 receptor 1, 12 interferon gamma axis. Okay. So what is the diagnosis? 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 Which of the following are true about the IL-12 interferon gamma axis? IL-12 is produced by the T cells and NK cells. Deficiency in this axis leads to susceptibility to environmental mycobacteria. Patients typically present with aspergillus infections. Safe to administer BCG vaccines to these patients. None of the above, which is true.
So most of the participants think it's B.
Yes, it's very simple because rest is all wrong. IL-12 is produced by the macrophages, not the T cells and NK cells. The T cells and NK cells produce the interferon gamma. So that is so patients typically present with aspergillus. No, they present with the environmental mycobacteria. Obviously, you can't give BCG to the patient; they will have full-blown BCGitis or BCG disease. Now coming to the T cell defects, let's have a very short look at how the T cells develop. Okay, T cells develop through certain stages in the whole process. From the multipotent hematopoietic stem cells. In the early stages, signaling through the cytokine receptors is very important, especially the IL-2 and the IL-17. These IL-7. These signals are very important for early lymphocyte development. So for IL-2 signaling, the IL-2 receptor is very important, and IL-7 receptor is very important for the cytokines to act. So the IL-2 receptor and IL-7 receptor on the lymphocytes is very crucial for early lymphocyte development. Later on, we have the RAG1 and RAG2, where the beta and the TCR gene rearrangements happen. And later on, they ultimately develop into double positive, then single positive CD4 or the CD8 T cells. Okay. And as I said, the signaling through the IL-2, IL-2, IL-4, IL-7, IL-9, and IL-15 is very crucial. And the receptor here is the IL-2 receptor and the IL-4 receptor, IL-7 receptor has this chain which is called the common gamma chain. So this common gamma chain is called a common gamma chain because it's common to all these receptors. Okay. So whereas the now here the IL-2 and IL-7 are very important for lymphocyte development, and IL-15 is very crucial for NK cell development. So even if there is a block in signaling, for example, the common gamma chain is non-functional, or there's a mutation in the gene for the common gamma chain, all these receptors cannot signal. So the IL-7 receptor cannot signal, so there will be no lymphocyte development. The IL-15 cannot signal, there will be no NK cell development. Whereas if there's a defect in the IL-7 receptor alpha chain, the common gamma chain is okay, but the defect is in the IL-7 receptor alpha. Only the IL-7 is not able to function here. So which means the NK cells are spared because the IL-15 will be functioning normally to the IL-15 receptor, but the IL-7 will be deficient, so there will be no lymphocyte development. So this component of the receptors is very important to understand how the common gamma chain affects the lymphocyte as well as NK cell development. Okay? And it's also the B cells are simultaneously developing. So it's important that the CD4 help is very crucial for the B cells to function. So the B cells always need the T cell help to functioning normally. So if there are no CD4 cells or the T cells are deficient, even the B cells, even if they are normal in number, they are not functional because they need the T cell help. So if the T cell help is not there, even the B cells cannot function. So tere bina main bekar. So T, no B without T. Okay. So remember that. So there can be defect here in these. If there's a defect in the IL-2 receptor gamma or the JAK3, there are no T cell development, but the B cells are normal, NK cells are also not there. So the phenotype of this kind of a defect would be T negative, NK negative, B positive kind of a severe combined immunodeficiency. So this is how what the pathogenesis is like. So if there is a defect there, for again, if there is a defect in the IL-7 receptor, same thing happens, but this time the NK cells are spared. Okay. So this will be a T negative, NK positive, B positive kind of a severe combined immunodeficiency. So that's how it works. And if there is RAG1, RAG2 defect, again, the same thing happens. The NK cells and B cells are spared, but there are no T cells. So Artemis defect, similar kind of a thing happening. If there is a defect in the MHC class 2, there's no CD4 cells, so it leads to a CD4 lymphopenia. If there's a defect in the ZAP7T molecule, it leads to CD8 lymphopenia. So this is how the specific defects arrests the lymphocyte development at certain specific time points of their or in their development. And this is how the whole thing works. Okay, so we divide depending on the presence of T cells, B cells, and NK cells, we divide the kids into different types, and we have all these genes that are responsible. So just by looking at the T cells, B cells, and the NK cells, you can almost pinpoint which gene would be the likely candidate where this patient might have a mutation. So let's have a look at this patient, 2.5, presenting very early in life, 2.5 months. Okay, symptomatic since day 15, had 3 episodes of pneumonia, complaints of fever, cough, respiratory distress. Remember, this is a boy and presenting very early with features of pneumonia and symptomatic very early in life. Lymphocyte count, if you see, if you look at the DLC here, you can see that just by looking at this, you may not be able to decipher that. You can just think that this patient has polymorphonuclear leukocytosis. Okay, but unless you look at the absolute lymphocyte count, you will not appreciate that his absolute lymphocyte count is so low. Okay, so it's very important to look at the absolute lymphocyte count every time you look at a hemogram and the differential lymphocyte count. Be very particular to look at the absolute counts, both the neutrophil count and the lymphocyte count. Okay, so this patient has very low ALC. Okay, immunoglobulin profile, everything is low here again. So IgG is low, IgA is low, IgM is low. And if you do a flow cytometry, you can see that there are no CD3 cells, no CD20 positive cells. So no T cells, no B cells, but the CD56 positive NK cells are there. So this is a boy who's presenting so early in life, a T negative, B negative, NK positive, severe combined immunodeficiency, because the NK cells are there. So just by doing a simple flow cytometry for T cells, B cells, and NK cells, you can pinpoint where the diagnosis goes. Another case, you can again see no T cells, no B cells, but the NK cells, almost all the lymphocytes are NK cells here. So this was again Artemis gene defect and a patient presenting with severe combined immunodeficiency. So sometimes if you see this kind of a history, family history, you can see so many male deaths occurring in the family here. Okay, this is an index patient. So this kind of a history should promptly give you the possibility of an X-linked disease. And if the patient is a 10-month-old boy, and this kind of an X-linked history in the clinic, or even in the when you see the patient, you should always ask, if you suspect this kind of a problem, you should always ask about the mamajis, okay, the maternal uncles. If you have this kind of a strong family history, X-linked kind of a family history, you should always suspect. So this is a patient of now sometimes T cells may be present, even if it's a typical presentation with very strongly suggestive family history. And you see that the T cells are there. If you can see, most of these cells here are T cells, but otherwise this patient is totally fitting into. So this could be, in this scenario, you have to rule out that these T cells are not of the fetal origin, but of maternal origin because of maternal engraftment. So you can do a activated memory and the naive CD45RA and CD45RO in this, because in a child, infant, most of the T lymphocytes will be naive lymphocytes, whereas if they are maternal engraftment, there's a very simple way to look at it. If they are T cells of maternal origin, and it will be all memory T cells, so CD45RO positive. So you can just have a vague idea of whether they are naive T cells or memory T cells. And this patient, the lymph node shows so much of tuberculosis here, all this acid fast bacilli here. Okay, so this scenario has to be kept in mind. Okay, you can do uh, staining for the 127 or the IL-7 receptor or the common gamma chain, can have antibodies and do a flow cytometry and look at whether these proteins are deficient in a particular clinical setting. So you can do flow cytometry for these molecules and you have a diagnosis. So which of the following are true about severe combined immunodeficiency? Patients have life-threatening opportunistic infections very early in life. Live vaccines can be safely given. B cells are non-functional and patients have associated antibody deficiencies. SCID is curable with early hematopoietic cell transplantations, and patient usually present in adulthood. Very simple questions. I put very simple questions. That's straightforward. You can have multiple correct answers.
So the answers are only slowly trickling in. I encourage the audience to please put in your answers. Okay, most of them are B. And
I think the audience did not realize that there can be more than one.
Yeah, there
correct
can, yeah,
answer.
more than. So let me, okay. Otherwise, simple questions, but okay. Patients have life-threatening infections. That is true. Opportunistic infections, obviously, in a SCID. So that's how the babies present very early in life with opportunistic infections. Live vaccines cannot be given in these patients. Okay? You cannot give live vaccines to these children, or else they will have devastating disease. Okay. B cells are non-functional. Yes, as I've already told you that B cells are totally dependent on the T cells. So if they're in a severe combined immunodeficiency, that's why it's called combined. The defect is in the T cell, but even the B cells are not functional because the B cells are dependent on the T cells. That's why it's a severe combined immunodeficiency, which means both the T cells and B cells are not functional. So B cells are non-functional and patients have associated antibody deficiencies, even though it is a T cell defect. This is true. Okay. SCID is curable with early hematopoietic stem cell transplant. Absolutely true. If you transplant these children very early in life, they can have a normal life. Absolutely normal life. Because SCID is a disease. We use the SCID mice for experiments where you do not want the animal to reject any graft or tissue. So because they don't have an immune system. This is similar. These patients cannot reject any graft. They just need a graft. You give them a graft and they will survive. They will accept it. So they are, it's curable. It's hematopoietic stem cell transplantation is the cure for SCID. Which otherwise is totally fatal, absolutely fatal. You cannot, that's why it's called SCID is called emergency. It's a clinical emergency. Patients present very early in life. In fact, in the first few months of life. So this is wrong. So we have 3 correct choices here. So another defect, the CD40 ligand expression. This is a six-year-old male child presenting with pneumocystis jirovecii pneumonia. Now, if the patient is HIV negative and you see a pneumonia due to pneumocystis in a 6-year-old male child, this should raise your suspicion. There's something wrong, okay? And there's a previous history of sibling death at a very early stage. So strong family history, a male child, and pneumocystis jirovecii pneumonia. If you look at the serum immunoglobulin profile, IgG is, IgG is low, IgM is high. IgM is 4.6, normal is 0.56 to 2.8. So IgM is high, IgA is low. Okay. So this kind of a scenario where IgM is either normal or high, in a setting where it's suggestive of a combined immunodeficiency, you should think of CD40 ligand deficiency, because this CD40 ligand, I'll come to it in a little bit from now. This interaction between CD40 ligand, which is expressed by the T cells, and the CD40, which is expressed by the B cells, this interaction is very important for class switch. Normally, a B cell is IgM producing. Later on, after antigen exposure and CD40 ligand interaction, the B cell switch to produce IgG and IgA. So if this switch doesn't happen, if the CD40 ligand interaction is not there because of defect in the CD40 ligand, this switch is not happening. That's why see all the B cells are producing IgM. They are not producing IgG or IgA because the shift hasn't happened. So this is called hyper IgM syndrome. This is X-linked hyper IgM syndrome because the CD40 ligand gene is in X chromosome. So that's why I see that it's a male child. So CD40 ligand expression here you see in the patient, it's absolutely not there. So this kind of a situation where you see that there is hyper IgM or normal IgM with low IgA and IgG, you should think of this kind of a defect either in the CD40 or CD40 ligand. If it is CD40, both the male and females can be affected because it is autosomal recessive. If it is CD40 ligand, it's X-linked, only boys will be affected. So case of hyper IgM syndrome. Now, we have seen development of T cells till the stage of CD4 and CD8 cells. So these are naive T cells up till CD4 positive naive. Now, depending on the cytokine milieu, these cells will further, differentiate into the T regulatory cells or the Th17 cells or the Th2 cells, T follicular helper cells, Th1 cells. So these are further, subtypes of the lymphocytes after antigen exposure, after activation. So you can see that these are factors, transcription factors, which are responsible for making or polarizing these naive T cells to these different subsets. FOXP3 is very important for producing the T regulatory cells. ROR gamma T and STAT3 is very important to produce the Th17 cells. GATA3 is present for important for Th2. Now, what happens if there is a defect there? In all these molecules, you're gonna hear you can have defects or genetic. These are basically, as I told you, these stars are patients and see these patients in the clinic. For example, if there's a defect in the FOXP3, what happens? The T regulatory cells cannot develop, and this gives to a. So the T regulatory cells are very important in suppressing immune response, okay, and controlling an immune response. So if you do not have the T regulatory cells, you have uncontrolled inflammation and autoimmunity. So IPEX syndrome due to FOXP3 defect is an X-linked, you can have polyendocrinopathies, which is X-linked. This is because of autoimmune. You can have autoimmune thyroiditis and a lot of autoimmune diabetes. Can have these autoimmune polyendocrine syndromes because of a defect in the T regulatory cells. Similarly, if there is a defect in the IL-10, now IL-10 is a cytokine that is immunosuppressive or it controls inflammation. So if there is a defect in the IL-10, now this I'm talking of the T cells after they have differentiated into CD4 and CD8, and if there's a defect in the IL-10, it leads to very early onset inflammatory bowel disease. So these patients can present very early in life with inflammatory bowel disease because these are autoimmune. So as I told you in the beginning, that these patients, not only infections, but autoimmunity can be a very prominent feature in these patients. Okay. Similarly, if there's a defect in the STAT3, that leads to blockage in of the Th17 cell. The Th17 cells cannot develop. Now, Th17 is very important in handling extracellular bacteria and candida. So if there's a defect here, the patients get chronic mucocutaneous candidiasis and the hyper IgE syndrome. Even here, the Th17 cells are not there in hyper IgE syndrome. So these patients had a lot of extracellular Staph aureus kind of an infection, extracellular bacteria and candida. Similarly, if there is a defect in the IL-17 cytokines as such, okay, that also leads to CMC or chronic mucocutaneous candidiasis. So you see that a specific molecule for a specific pathogen, because that molecule is so important in handling that particular pathogen. And if that molecule is not there, only that infection happens. So IL-17 defects, it leads to only candidal chronic mucocutaneous candidiasis, and the rest everything is fine. They just can't handle candida. So that's specific kind of a defect. Okay. So which of the following are autoimmune manifestations of T cell immunodeficiency? IPEX, very early onset IBD, CMC, CGD, LAD. So this very simple question. I actually Don't have to wait for the response also, because this has to be correct for all. Okay.
ABC.
ABC. AB is okay, but not C. C is not an autoimmunity, because see, I'm talking about autoimmune manifestations. The Apex syndrome and very early onset inflammatory bowel disease, these are defects in the FOXP3 in the T regulatory cells. So that leads to the autoimmune kind of a manifestation. So A and B are correct. C and D and E are infectious complications, not rather than autoimmune. So A and B. Okay. So another case study, a 3 years male presented with recurrent scalp and oral candidiasis in early infancy and verrucous lesions in the penis, and Th17 cells were low. Okay, and when we did the phosphostat 1, it was hyperphosphorylated. So stat 3 and stat 1, they're uh, opposite in action. So as I said, stat 3 deficiency will lead to candidiasis. Similarly, stat 1 hyperactivity will also lead to candidiasis. So this is a STAT1 gain of function mutation. As you can see, even the flow cytometry shows that the STAT1 is overactive here. It's more than the control here. So when you this patient's this defect, the gain of function mutation in the STAT1 leads to chronic mucocutaneous candidiasis. Okay, again, this patient present with a lot of mucocutaneous candidiasis. So this was a patient of CMC because of a defect in the STAT1 gene, which is a gain of function mutation. Okay. And this is a case study of a 2.5-year-old male child presenting with skin abscesses, pneumonia, pneumonia with Staph aureus. He had empyema. And if you see, the absolute eosinophil count was very high in this patient, 21,000. And the IgE was markedly raised, 9,752 international units. So if this kind of increased IgE with raised eosinophil count, patient presenting with Staph aureus infections, pneumonia, empyema, and a lot of skin abscesses. Now, this constellation of findings should prompt your diagnosis to a hyper IgE syndrome. And you can look at the phosphostat 3, because as I told you, the stat 3 is very important for development of the Th17 cells. Okay, so if there's a defect in the Th17, the patients have staph infections and candidal infection. That's what I said. So this is a case of hyper IgE syndrome. When you look at the Th17 cells, these 17 cells are very low, 0.3 compared to the control. Phosphostat 3 is reduced. And when you do analysis or genetic analysis, we found a very novel mutation here in the STAT3 gene, which was actually a stop codon. We don't have many patients with stop codon in the STAT3 gene, nonsense mutations. And this is one of the rare patients that we had encountered in our cohort of hyper IgE syndromes. Now, lastly, coming to the B cells. Similar to the T cells, the B cells also develop through these stages of development. In the early stages, the signaling through the RAG1, RAG2, these signaling molecules are important. From pre-B to immature B, the BTK or proton tyrosine kinase enzyme is very important. And after the cells have, from this pre-BCR and become an immature B cell, it comes to the periphery as a mature B cell and is producing, expressing surface IgM here. And after the class switch happens, it will produce IgG, IgA, and Ig. That's what I told you, because this interaction of CD40 ligand and CD40 is important for class switch. So this M producing B cell becomes a G and A producing B cell here, okay, which then further differentiates into a plasma cells and start producing antibodies. So this is how, till this stage, the B cell is in the bone marrow, and only when it is mature and producing IgM, it comes to the periphery, okay. Now whole thing happens in the Jamal center. So that's called a Jamal center reaction. Now, if we have a defect here in the RAG1, RAG2, and the very early stage of when the B cell is converting from a pro-B to pre-B, if there's a block, any of these molecules, there will be no B cell development. Okay, cells will be there, but no B cells, absolutely. So hypogamma with no antibodies at all in these patients. So, and if you have a defect here, for example, in a BTK with a pre-B to mature B, again the same thing happens. There are no B cells in the blood of these patients. Okay. So if there's a defect in the CD40 ligand, I already told you that because this class switch doesn't happen, there are no IgG or IgA producing B cells, no plasma cells here. It's cut off here. So only B cells, the patient will have a lot of B cells in the blood, but they are all IgM producing. So this is what gives rise to the hyper IgM syndrome. And if you have a defect in this is CD40 ligand defect, this is X-linked, this is autosomal recessive. So the same kind of a picture of hyper IgM syndrome can be there. So if we have a defect in the later stage in the switch B cell, in the, for example, in the ICOS or the BAFR or the CD19 or the TACI, this gives rise to what we call as CVID. What in this, we have the B cells normal in number, but they are not producing because the differentiation into plasma cells is blocked. So there are no plasma cells. So these patients they have hypogamma-globulin. All the isotypes would be there, but they are reduced. They have hypogamma. So this is what you typically see in the common variable immunodeficiency or the CVID. Okay. So if you look at the serum immunoglobulins, low IgM, low IgG, IgM, and IgA, or two isotypes, then you can think of a CVID or a hyper IgM syndrome. Okay. If there's a defect in this is subclass G1, G2, or G3, only IgA, think of the selective IgA deficiency. Only IgM is low, think of selective IgM deficiency. Okay. If there is IgG and IgA are low with normal or raised IgM, you think of a hyper IgM syndrome. So this is the kind of thing you can see in when you do a serum immunoglobulin analysis. And B cells will be, however, normal in this situation. Okay, in all these situations, B cell numbers will be normal. Whereas in the early, if there's a defect in the early B cell development, there's pan-hypogamma-globulin because there are no B cells at all. It's arrested in the bone marrow itself. So there's no B cells, they're present in the peripheral blood. So patients will have pan-hypogamma-globulinemia. All immunoglobulins will be low and B cells will be absent. So in the early B cell development blockage, there will be B cells absent and pan-hypogamma-globulinemia. Whereas in the later stages, if there is a defect there, you will have normal B cells present, but they have hypogamma-globulin and different combinations. I already told you. So there's a 2-year-old male boy presented with recurrent episodes of diarrhea and multiple episodes of pneumonia since 6 months of life. 6 months, okay. As I told you, the early few months are protected. So this presentation at a later stage is very important. 2-year-old boy, 6 months, bilateral discharging ears. If you look at the immunoglobulins, everything is low. GAM, everything is. So pan-hypogamma-globulinemia. If you look at the B cells, there are no B cells here, no CD19 cells. Everything is T cells here. So this is X-linked agamma-globulinemia, which is defect in the BTK protein. If you look at the flow cytometry for BTK, now, if you in the flow cytometry, you have to look at the monocytes because B cells are not there, so you cannot look at the B cells. So if you look at the BTK protein expression in the monocytes, you can see that the BTK expression is very low in these patients. So this is the X-linked agamma-globulinemia because of a defect in the BTK, which is also called the XLA or the X-linked agamma-globulinemia. So you do a BTK gene sequencing, you have the diagnosis. Another case, now this is a 28-year-old man, an adult, was presented to gastroenterology. Symptomatic since 10 years of age, recurrent diarrhea, pneumonia, and sinusitis, significant weight loss, and no significant family history. Okay. Immunoglobulin profile, there's pan-hypogamma-globulinemia. So, but when you do the B cells are normal. Okay. So B cells are there, but still the patient has hypogamma-globulinemia and he's an adult. So if you get this scenario in an adult patient presenting with infectious complications, recurrent pneumonia, they sometimes present with bronchiectasis, a lot of lung inflammation and damage happening. If they present very late, you will have a lot of bronchiectasis. So if you have this scenario, then you think of common variable immunodeficiency or CVID. Then you have to look at the B cell subsets. And if you look at the switch memory and the unswitched memory and the naive cells, So by looking at the B cell subsets, you can pinpoint where the arrest is. Okay, if there is an arrest in the early development or early this thing, all will be naive cells. There will be no switch memory B cells. So by looking at the subsets, B cell subsets, you can actually pinpoint where the defect is. So you can do flow cytometry by using this panel. All these antibodies, we can look at the different subsets of B cells. So antibody deficiency disorders, they present with susceptibility to bacterial infections, absent tonsils, hypo or agamma, enteroviral infections, all of the above. So all these, I don't even need to ask because it's all of the above. Everything is correct here, all the choices. This antibody deficiency disorders, they give susceptibility to bacterial infections and enteroviral infections. Remember, bacterial and enteroviral infections. Polio is very common, susceptible to polio infections. Absent tonsils, hypo or agamma-globulinemia when you do the serum immunoglobulin analysis, and the patient also have enteroviral infections. So all these are true for antibody deficiency disorders. Okay? And if you do a biopsy in a CVID patient, they can have abscess of plasma cells. Is a very important clue in a typical clinical setting. If you do need to do a biopsy of the gut and you don't see any plasma cells, so there are different patterns of gut pathology that can be seen in patients with CVID. Ulcerative colitis-like pattern and Crohn's disease-like pattern. You can have a lymphocytic colitis pattern and collagenous colitis pattern. You can have granulomatous inflammation. You can have a lot of viral infections, including the enterovirals. And you can also have lymphoid aggregates. Okay, look at these lymphoid aggregates in the rectal mucosa. It's a common in the colon in the CVID patients. But though because the arrest in the B cell development, there are no plasma cells, but presence of plasma cell does not rule out CVID. That's an important thing. If you do not see plasma cells, it supports your diagnosis of CVID. As a pathologist, I'm saying, though you may not encounter a biopsy in many patients, in many of these patients, but if you do so, absence of plasma cells is a clue to the diagnosis of CVID. And this kind of lymphoid aggregates can also be seen in a biopsy. And in the lung, you can have a lot of granulomatous lymphocytic ILD kind of a scene. So a lot of granulomas, and this can be often misdiagnosed as sarcoidosis because you don't see organisms here, and you have a lot of granulomatous inflammation in the lung and ILD-like pattern. So this can be seen in CVID patients. So we have the feeling, though, that many of these patients who are diagnosed as sarcoidosis will ultimately turn out to be CVID if we look at them carefully. Okay, so only a fraction of the CVID patients have a known genetic. Majority of the CVID patients, we do not have a gene known for these patients. Another patient. Now this is an elderly patient. This is the last case I'm showing you. This is a 53-year-old male with history of prolonged episodes of diarrhea for 8 years. He has been having these episodes of diarrhea for a very long time. Old man. Microscopic examination of stool that showed giardia. Okay, they treated with metronidazole, and he improved. And again, he was readmitted a month later, again with the similar complaints. And GI endoscopy again showed, and biopsy again showed presence of giardia. I can see giardia here. And this patient on history turned out that this patient had a few years back, he had a thymectomy because of thymoma. So the thymoma with hypogamma, and when you look at the investigations, you can see that the IgG is low here. Okay, IgM is also low. B cells are low. Hardly any B cells there. Okay. So if you in an LA and CD8 count is raised, so CD4 CD8 ratio is, so these are all immunological findings that you could typically see in a patient with Booth syndrome. So a patient, elderly patient presenting either a preceding or incidental thymoma and presenting with B cell deficiency, absence of B cells and hypogammaglobulinemia, your diagnosis is thymoma with hypogammaglobulinemia, which is called Booth syndrome. there's nothing good about this syndrome because the prognosis is very poor, and even compared to other humoral immunodeficiencies, the prognosis is poor. And even this patient actually succumbed to this illness in spite of getting a lot of adequate intravenous immunoglobulins. This patient did not survive. So this, if you encounter this kind of a problem in an elderly patient, always think of a good syndrome. And though these are rare, but you should always know. So when you talk of, as pathologists, when I talk of the laboratory screening of these patients, I cannot, overemphasize on looking at the carefully at the complete blood counts here, the TLC, DLC, and the platelets for Wiskott-Aldrich syndrome, which also can have antibody deficiencies along with that syndrome. So platelet size is very important. The platelet count, many of these PID patients, especially the Wiskott-Aldrich, presented thrombocytopenia. So the very careful look at the CBC and very careful look at the absolute lymphocyte count and the absolute neutrophil counts. I did not talk about the neutropenias, but that is also a very important phagocytic defect, all the congenital neutropenia and the cyclic neutropenia, which are basically the hematologist's domain, but they can have a lot of associated immune deficiency because of hypogammaglobulinemia and both T cell and B cell defects. So very careful look at the absolute counts, lymphocyte as well as the neutrophil count is very important. And I cannot overemphasize on this fact. Looking at the serum immunoglobulins will give you, give you a clue to your diagnosis. It's not difficult to diagnose CVID or hyper IgM syndrome or a pan-hypogammaglobulinemia with absent B cells with the XLA. And then the lymphocyte subset analysis, you can look at the T cells, 4 and 8, B cells, NK cells, and these give you very important clues. So for a pathologist, we depend, for PID diagnosis, we depend on 3 techniques: CBC, the nephelometry, and flow cytometry. So if you have these 3 techniques with you, you have the full, this thing for diagnosing the PIDs. Okay. So for T cell deficiency, you would look at the T cells, obviously lymphocyte count, and T cell subsets and NK cell enumeration. And you can do in vitro proliferation assays. You can have an NK cell cytotoxicity assays. But flow cytometry will give you most of the answers in whatever T cell defect you are suspecting. For the B cells, obviously the serum immunoglobulin assays, you can also look at the subclasses, the B cell numbers by employing CD19 or CD20, but always keep in mind that there's a CVID, which is because of the CD19 defect. So if you are using only CD19 and you don't see CD19, so you can have a false impression of no B cells in a patient which is CVID because of CD19 defect. So in that case, you have to use CD20. So if you have to detect the CD19 defect in a patient presenting with CVID-like features. So you have to also have to look at the antibody responses, and the antibody responses to carbohydrate antigens are very important because this is what is T independent. So if you look at the T dependent antigen vaccine responses to T dependent antigens, then you are also looking at the T cells. Okay, so we want to look at the response which is only by the B cells. So you have to look at the T independent or the carbohydrate antigens. So you have to look at the titers to Pneumovax or Salmonella typhi. So you can look at the antibody responses to these vaccines. For phagocyte, you can look at the 11, 18 for diagnosing the LADs, Bombay phenotype for LAD type 2, NBT slide test I've already told about, DHR I've already spoken about, and flow cytometry for specific proteins like these for diagnosing the different types of CGD. So this is I just tried to give you a rough layout and very basics of it's a very huge topic and it's difficult to cover all the diseases in one topic, but I just gave you an overview. And thank you. I end my talk here. And I talked of so many genes, but we have one gin. I'm not talking of the gin in a bottle. I'm talking of the gin that comes out from a lab. So we have a gin sitting among us. That is Dr. Mukesh Desai. He has answers to all the queries, all the questions. So now I request Dr. Mukesh Desai to kindly answer any questions that may come from the audience. Dr. Mukesh, if you're there. I'll end my slideshow here.
Thank you, Biman, for this very generous introduction. I think this was a lovely talk by you, and it covered most aspects of immunology. It gave some clinical perspective. It gave us an approach to all the disorders, and it told us also in a very graphical manner exactly at what stage and what step that is the defect, so that you can actually understand it. So this should form the basis on which students can really take off. I just want to make a few comments which I think I have from my personal experience what I have found. So one of the things is that simpler investigations can never be forgotten while we look at flow cytometry and more advanced investigation. So sometimes the diagnosis may be a simple peripheral smear. So say for example, somebody has a congenital neutropenia unless you look at the peripheral smear and find the absence of neutrophil, because sometimes these patients have adequate eosinophils. And that the Coulter counter will give you that there is 10% or 15% neutrophils. And very often it is missed. I've seen a child in whom the diagnosis was missed for 2 years. A child had already had a liver abscess, mastocytitis, everything. And a simple peripheral examination gave us the diagnosis that it was a severe congenital neutropenia. So simple investigation should not be forgotten. The pathologist should focus a lot on the CBC, as Biman has already emphasized to you, that the absolute lymphocyte count is the first thing which we look at. As immunologists, the hematologists focus on the absolute neutrophil count. But Biman has also told us about eosinophil counts and many other things which could be of interest which you can find. Another thing which can be of interest could be a monocytopenia, setting of tuberculosis. If somebody has got tuberculosis and you have monocytopenia, think of a GATA2 deficiency. There are some very interesting changes happening in the hematological world and world all over, where we are now finding that there are many leukemias which have genetic basis, and these patients who need to go for transplantation, you need to look at the gene. So I think Biman, for want of time, has not told you about the need for doing a genetic testing. He has emphasized it, but I think NGS is now very often ordered, and many patients come to us with an NGS report which is not giving them the diagnosis, or an NGS report with a VUS, and they don't know what sense to make out of this. So in this situation, I want to re-emphasize that once again, you have to have your clinical story which is very solid, so you can make more sense about what the diseases could, what the possibility, whether the VUS is really a disease-causing mutation or not. We have hardly looked at somatic mutations. I think that is another big thing which is going to be there. And I think autoimmunity, as he has already emphasized to you, immune dysregulation is the next big group of inborn errors of immunity which we look at. At Vade children, when we looked at dysregulation of one autoimmunity or double autoimmunity or polyautoimmunity, we found almost 50% having an inborn error of immunity, which is a huge number. And we had another 12% who had a VUS which fitted with the clinical diagnosis, but we were not sure to include them as as the disease-causing mutation because we didn't have definitive evidence for that. One thing which I would really urge Biman is that sometimes we have a patient who has a diagnosis of inborn error of immunity, which all are convinced, but your NGS and other investigations have not given us the diagnosis. So as clinicians, we would expect from the pathologist, especially somebody like Biman, to give us any functional pathways which are affected. Like say you have STAT phosphorylation which is hyperphosphorylated. Then we can use a JAK inhibitor or something, because now we have a lot of molecules which are available to us by which we can modulate the immune system. One classical example is use of sirolimus for patients who got mTOR hyperactivity. And ALPS, STAT3 gain of function, STAT1 gain of function can be benefited with, IPEX can be benefited with drug like sirolimus. I think EBV-driven lymphoproliferation or lymphoproliferation is another big thing where the histopathologist is going to be always wondering whether he's dealing with a malignancy or is dealing with a just lymphoproliferation, or whether he's dealing with a polyclonality before it becomes monoclonal and becomes malignant. And we are seeing a lot of patients where there's a confusion between EBV, Hodgkin's lymphoma, yeah, EBV, and other types of lymphoma. So when we have this kind of situation, I know the clonality is going to help us. But these are the situations which are classical situations where we need workup for inborn errors of immunity. And an alert histopathologist can tell us that. Biman has already told you about granulomas. Not every non-caseating granuloma is a sarcoid. It's more likely to be a CVID than a sarcoid. And I think that point needs to be re-emphasized for everybody. And I think from tuberculosis point of view, as a histologist, if you see exuberant amount of AFB in any sample, you should get alert that this could be an inborn error of immunity. If you ever isolate an non-tuberculous mycobacteria, you should immediately get alert that this could be a Mendelian susceptibility to mycobacterial disease. I think another thing which we would like pathologists to encourage is that any histological specimen which are taken out should also be cultured. I think culturing a specimen taken out would be very important, because sometimes when you culture a lymph node in a child who's got immune deficiency and you isolate a non-typhi salmonella, that gives us the clue. Not only gives us the clue for the diagnosis of a molecular defect, but also gives us a clue about the molecular defect. That means this could be an MSMD, and this could likely to be an IL-12 receptor beta 1 defect, which is the most common defect. So there is this whole gamut of thing where the pathologist and clinician interaction can be extremely beneficial. I'm just talking about the, the routine pathologist. I'm not talking about Biman and people who are in tertiary care institute who has got access to all the laboratory facilities which are available. But they are the one who can pick up, pay attention to the absolute lymphocyte count, pay attention to EBV-driven lymphoproliferation disorder, pay attention to autoimmunity. These are the things which will lead you to underlying immune deficiency. From microbiology point of view, I think Biman has really emphasized it well that knowing the organism very often gives you the clue to the underlying immune deficiency. And one classical example he has told you about CGD. So aspergillosis in a non-neutropenic setting, if you ever have on your histology, you must rule out a CGD. So Burkholderia cepacia, Serratia marcescens osteomyelitis. In fact, every liver abscess, every lung abscess, every osteomyelitis needs an NBT and DHR to be done to rule out chronic granulomatous disease. So there are a lot which we can go on and talk. I think we'll take some questions if there are any. And my co-host Shrutika can intervene and join in at this point. So I think Biman,
sir.
thanks for a very, very challenging and very making it a very interesting talk
Yes.
of a very challenging subject.
Yeah, it's a very wide topic to cover. So I in fact left out many of the disorders. I did not touch the autoinflammatory. I did not touch the, the phenocopies of PID. I did not touch many other things, complement deficiencies and all. So yeah, thank you, Mukesh. Thank you for those very valuable comments. Thank you.
Yeah.
Yes, we don't have any questions so far. It seems like everyone has completely mastered the art of immunodeficiency. Sir has made it that easy. But yes, we do have an amazing feedback from the audience. They all are very grateful, and some that immunology could also be so interesting. It's generally considered as a dry topic. I take this time to.
I think Dr. Kavya has raised hand. Does anyone wants to speak up? Dr. Kavya, is it possible for you to put up your message in the chat box? Okay, I think it might have been by mistake.
I missed it, right.
Can I make a comment?
Sure.
I just want to make one interesting comment that Biman has told you about the IUS classification and the number of monogenic defects which can lead to inborn error of immunity. But I want to emphasize to all of you that they were considered to be a very rare disorder. But now, if you really see, they are much more commoner than what we believe. So I think the whole thing will, your ability to pick up an inborn error of immunity will depend on you going beyond the immediate diagnosis. So somebody has got a pneumonia, you need to ask this fundamental question, why this child has got pneumonia? And then you investigate him and you'll find that it will lead to you to an underlying inborn error of immunity. But I think this incidence is even commoner than hemophilia, and I think it will be recognized subsequently as the most common disorders clinically in all over the world. And I think that is where everybody is going, because everybody is now thinking that a single episode of infection can be a severe infection, can be a manifestation of underlying immune deficiency. And Dr. Casanova's group has already shown that the genetics of infectious disease is more the norm than an exception. So somebody develops a complicated infection, there has to be underlying genetic problem, which if you look for more, you will find them more and more.
Absolutely.
Absolutely.
There is this school of thought, which is saying that every individual is immune deficient. Somehow you cannot have a perfect 100% perfect immune system. Some or the other molecule will be either hypofunctional or not working, or somehow it's just a matter of getting exposed to that particular pathogen and you get the disease. So there's some of the disorders so organism specific, like this thing TLR9 defect, only herpes simplex virus, bus, nothing else. So it's so organism specific. I mean, individuals can be absolutely normal, live a normal life if he doesn't get exposed to the herpes simplex. But if he gets exposed to it, he's gone. So that kind of a thing, So it's very interesting. Immunology is very interesting.
Amazing. That's great. Thank you very much, sir, for your insights. I would like to thank Saikia, sir, for making it really simple and amazing. And even I'd like to thank Dr. Desai, sir, for his valuable clinical inputs. The combination was excellent. And there were some insights which actually you would not have got even after reading on the topic. So thank you very much, sir, for valuable time.
Thank you. Thank you so much. Thank you for attending. Thank you very much.
Thanks.
Bye-bye.
Bye.